hopefully.
Okay, so we're live, Lorraine. Okay.
Fantastic.
So, hello, people who've joined us already. We'll make a start in a little while, but we'll wait a few minutes for other people to join us. Welcome to this Facebook Live event from Dementia Carers Count, and the topic today will be delirium. Whilst we're waiting to see if anyone else joins us, then do feel free to start putting any questions you have in the chat box, and we will try and cover them during this Facebook Live in the next 30 minutes or so. So do feel free, type away. And we'll just wait a few moments. You wait, Lorraine, they'll all start coming in, all those comments will start popping into the box in a minute, and the challenge will be to see if we can get through to all of those questions, and hopefully we will do. Hopefully we'll be able to manage to answer them all in this session. But for those of you who've joined us already, if we don't get to all the questions within the session, then Lorraine and I will go through them after the session and have a look and respond where we can. Okay, so we'll make a start now, if that's okay, Lorraine. Hello, everyone again, and welcome to our Facebook Live event. This event is part of our launch programme for our Dementia Carers Count Virtual Carers Centre, or as we like to call it, the VCC. It's a centre that's online. You can go to our website and link into the Virtual Carers Centre, and it's there for family members and friends who are looking after somebody with dementia. You can visit the Virtual Carers Centre at any time you like, day or night, and there's a wide range of support and information there. Some of it in video form, some of it audio, there's written information, all sorts of types of documents and so on that you can access, which we hope will be of help to you. Everything on there has been put together by our range of health and care professionals, including Lorraine and myself, and we hope the topics are useful for you. The kind of topics that are there are things about managing your own emotions, developing your own resilience, everyday challenges that you might be facing in terms of things that are happening with dementia, looking after, as I say, your own physical and emotional health and the health of the person that you care for, and also more about the brain and how dementia affects the brain and the different types of dementia. But it also covers, of course, the topic that we're looking at in this live event today, which is delirium. So just to introduce ourselves, my name's Sue Hinds. I'm a practitioner at Dementia Carers Count and Head of Services, and spent many years working in the field of dementia. My background, speech and language therapy. And I'm going to just let Lorraine, introduce herself, because she will be the one who will be taking most of your questions today.
Good morning, everyone. My name's Lorraine Haining, and I'm a specialist practitioner with Dementia Carers Count. I've been with them now for about 2.5 years. My background is in nursing. I worked a very long time in nursing. I'm a mental health nurse, but for the last 20 years of my career, I worked specifically in dementia. And my father also had dementia, so I can see it from the carer's perspective as well. I've also had a very keen interest in delirium over the years, because I think it's something that people don't know a lot about, and it's quite important. So very happy to be here today to spread the word.
Thank you, Lorraine. And I think you're right. It's one of those things, isn't it, that sometimes goes missed, particularly when you're supporting someone with dementia. So I think you particularly, but both of us really felt this was an important topic for us to cover. Yeah. So before we get into the topic and start answering some questions, I just want to do a little bit of housekeeping. And that's to say, as much as Lorraine has sort of filled you in on her background and her experience, and she is definitely an expert in this field, she's not going to be able to provide any form of diagnosis or individual assessment during this call. Her answers will be more about sharing helpful information that she feels is of use to you and answering your questions. But if you need more specific advice, then we really suggest that you go to either your GP or your dementia team, who can help you specifically with any situations that are arising for you. We are recording this session, and it will be uploaded to our YouTube channel, so you'll be able to go back and look at it again at any time in the future that you wish to. And if we don't get around to answering all your questions during the session, then still we will look at them. We'll look at them after the session, and we will get back to you wherever we can. And I'll give you some more details about other options at the end of this session. So if we can start with the topic today, and as I say, the topic is delirium. And we've had some questions already in, Lorraine, so I'm just going to kick off with the one at the top, really. And this is from someone who says, I have been told this is what my dad has, but I'm not sure what it actually is. Are you able to help with that?
Yeah, well, delirium it's actually a very common condition, but it's also a very serious condition as well. So it needs to be addressed, and unfortunately, often gets missed in certain situations in particular. It's a condition that occurs suddenly, so it happens over a few hours or a few days. So it's quite different to dementia in that way. You can see the person in the morning when you go in to give them their breakfast, and you might come back at lunchtime to give them their lunch, and you find a big change in their presentation. It's a particular risk for older people, and particularly people with dementia. It will affect the person's ability to process information, so their cognition, and they can become really confused, or even more confused than normal if they already have a dementia. And they can quite often become disorientated for time and place, not really recognising where they are and who's around them. They have real problems with inattention, so their ability to pay attention, take information in, process it, and also to concentrate on things. And that's very evident. The other thing that's different from dementia is there are changing levels of alertness. So people will fluctuate from being quite anxious and agitated and restless to becoming very sleepy and drowsy and quite difficult to rouse. Their sleep pattern can often change, and quite often people will turn day into night. They're more awake during the night, and they quite often will sleep all day. So that's just really kind of what delirium is, just a quick overview. But as you said, there's more information on the website.
That's great, thanks, Lorraine. And I think that's one of the key things you said there is it's the fluctuations, isn't it?
Yeah, absolutely.
They can be quite marked. So it's an important thing to look out for.
Yeah.
You mentioned about somebody with dementia is at more risk of a delirium, and we've had a couple of questions in, so I'm going to put the two together. It'd be a bit of a double question, I'm afraid, Lorraine. So one question has been, is there anything that puts someone more at risk of getting delirium? But we also had another question, is there a higher risk of delirium in people with dementia who catch COVID-19? There's
lots of risks and causes of delirium, really. So if you're an older adult, if you're over 65, the older you get, just like a lot of conditions, the more likely you are to develop it. But also if you've got dementia, people with dementia are actually 5 times more likely to develop delirium than somebody without. So it's a very high risk factor, that. Obviously, as you get older, we get frailer. So that element of frailty can also cause conditions, because quite often people have what we call comorbid conditions. So they have more than one health condition. So they might have diabetes, COPD, and arthritis. It's just the overlapping conditions can cause complications, and that can lead to delirium. There's also quite a bit of research to show that people with hearing loss or sight loss are also more at risk as well. And if you've had an episode of delirium, you're much more likely to go on and have another. So again, just be mindful of that, and then you can nip it in the bud. Immobility, so people that are very sedentary and don't move around a lot, that can be, again, a big risk factor. And particularly people who've had falls, and particularly hip fracture. 9 times out of 10 people will go on to have an element of delirium in their recovery with that, just because of the complexity of it. If you're prone to infections, so if you, quite a lot of older people will be prone to UTIs, urinary tract infections or chest infections. And again, that's one of the biggest causes of delirium. If you're on lots of medication, so again, the complexity of the medication, the side effects, the interactions between the medications, and sometimes people don't take them correctly, and that can lead to delirium as well. Alcohol misuse, again, and alcohol withdrawal. So if somebody stops suddenly or doesn't have access to alcohol, that can cause problems. And there's also a risk at end of life. There's a lot of people, when they get to those last days and hours of life, can end up developing a delirium as well. In terms of COVID-19, that we're in the early days of understanding that, actually, but yes, there is a higher risk of somebody with COVID-19 going on to develop a delirium as well. But as I say, we're early, it's early days yet with the research around, how that's actually affecting the person. But yes, absolutely.
And that would make sense, wouldn't it, from everything that you've said about infection and medication and so on.
Absolutely.
And there was a comment, Lorraine, whilst you were talking, actually before you got to it, in what you were saying, and it sort of confirms what you were saying as well. Somebody has said, my dad seems to get worse delirium when he is starting with a bladder infection or kidney function is reduced. And that's what you said, wasn't it, when you said UTI, the urinary tract infections?
Yeah, absolutely. Huge issue.
Okay. Thank you, Lorraine. So another person here said that her husband has been told he has a mixed delirium, and isn't sure what that means.
Yeah, well, there are 3 types of delirium that are actually really well recognised. There's hyperactive delirium. So that's when the person becomes really confused, and they become quite anxious and agitated and very restless. They really find it hard to kind of stay in one place or settle down at all. And that kind of accounts for around about 20% of people with delirium. And then we have what we call almost like a flip side. It's a hypoactive delirium, where the person becomes very drowsy and very sleepy, really withdrawn, and quite difficult to rouse. So their functioning is really, in their boots, really. And that again kind of accounts for about 50% of people. And then what we have is a kind of combination of these two, where we see it fluctuating between these 2 different conditions. So, and that's where we get this term mixed delirium. So we actually see people fluctuating between the hyperdelirium, where they're agitated, and the hypodelirium, where they're actually sleepy all the time. And the mixed delirium is around 30% of people. The hypoactive delirium tends to be the more the one that's often missed, because the person's very quiet and you don't pick it up early, and also it's got the worst outcomes for the person as well, because it often doesn't get treated early enough. So I hope that explains it a little bit for the person to understand.
Thanks, Lorraine. I've got questions coming in thick and fast, and just to let people know, I'm not necessarily doing them in the order that they come in, because I think we've looked at risk. We're now looking at some of the presentation, and those that are around how we manage it, I'm going to leave a little bit so that we go in some sort of order. So you've talked about hyper delirium and mixed delirium. And another person has said that they've been told that the person they care for has acute confusion. Where does that sit in it all?
Yeah, acute confusion actually is just another term for delirium. I think over the years, delirium has, well, a lot of people have tried to change the word, and actually it's confused people. But we're actually at this point, in the last few years, we've tried to kind of very much stick to delirium as the diagnosis. But you will hear acute confusional state, so people will refer to that, or a toxic confusional state is something else that might be used, or toxic psychosis. And sometimes we'll hear people talk about acute brain failure. So these are the kind of things that the professionals will talk about. Sometimes carers describe it quite differently. They'll describe it as like being a bit muddled, not themselves today, they're a bit knocked off, more confused than usual. Those kind of terminologies we tend to hear. And if we hear that from a family carer, we tend to be alerted to something is wrong. But acute confusional state really is just the same as delirium.
It's confusing when there's so many different terminologies for things, isn't it?
It really is, yeah, absolutely. And it's confusing for professionals, so it must be a lot more confusion for family carers, actually, yeah.
Okay. But what you're saying really is that an acute confusion is the same as delirium.
It's just the same as delirium, yeah.
Okay, thank you. Let me, so a question here around the sort of delirium, acute confusion and so on. Can it speed up dementia?
Yeah, unfortunately, there's some evidence to show that it actually can increase the decline of the person, while they're going through that episode. There's a definite risk factor there. As I said before, people with dementia are a lot more likely to develop it. Again, and I think that's because there's an underlying vulnerability to the brain already, so the person's already got the dementia process going on, and then we've got that overlapping vulnerability from and the kind of complication of the infection or whatever it is that's causing the delirium. And there's certainly growing evidence to show that there are certain anaesthetics that kind of post-op will affect the person again. And maybe even trigger on new onset dementia as well. So sometimes people don't have it before, but after the operation that they have, it can actually trigger it as well.
Okay, thank you, Lorraine. So you've mentioned the word trigger there. I think we'll move on to some of the sort of prevention and early detection, if we can. Is there anything in general you can do to prevent delirium?
I think it's really just been, well, the first thing really is to be aware of it. I think that's the first thing. I think to say it's actually important to try and be aware of it, and then you'll hopefully pick it up. I think be mindful of any sudden change. I think and the first thing to do is ask for an assessment. So go straight to the GP and ask them to actually try and give you some advice around it as well. If the person's prone to infections as well, I think as soon as that infection kicks in or you get signs and symptoms, get it treated immediately as well. There's some of the risk factors, as I say, if you can try and minimise those, that can also be very helpful. And I think it's really important to try and get regular medication reviews so that you are never at risk of medication causing a delirium as well. So they're the sort of some of the main things that certainly would be helpful in prevention. As I say, it's just being mindful of it and looking out for it, accessing support as soon as you possibly can, and making sure your medication and your condition is reviewed in a regular by somebody regularly.
Okay, and this one is a bit more specific around prevention, actually. This one is, my dad has a catheter in place and has had 2 episodes of delirium. How can I help prevent it from happening again?
Yeah. Actually, a catheter is, again, a quite high risk factor. So somebody who has an indwelling catheter has a much higher risk of developing delirium. It can sometimes allow bacteria to enter into the body, through the tube that goes into the bladder, and that can cause infections in the urethra or the bladder or the kidneys, which we would know as UTIs. I suppose the first question for me would be, does the catheter have to be in place? And does it have to be in long term? For me, I think catheters should be in and out as quick as possible if they need to be used at all. It should be really used for a clinical reason. Again, I think it's helpful if you've the family members can take a note of keep a diary of the changes and the symptoms and the timings, etc., and pass that on to staff so they can be mindful and more aware of it. And again, very quickly access treatment when you see those early warning signs of the infection coming along. So I think share with the staff if there's already been a previous episode of delirium, so that they'll look out for it and be more aware of it as well. You might notice that there are some early warning signs that can help you to pick up at an early stage. So the person might become more agitated. They might complain of discomfort from the catheter itself. You might notice changes in urine and the colour of the urine. So write these down and pass them on to staff that are looking after the person as well, and contact the medics as soon as you can for support as well. And if the person goes into hospital, it's about making the staff aware that they've been prone to infection in the past as well. So yeah, we want to try and stop it in its tracks as well. Sorry,
carry on.
No, that was it. That's fine.
So I think that feeds into quite a lot of the comments that are coming in, Lorraine, about being able to detect it early, writing down what are the early warning signs for you.
Absolutely.
and you know, being confident to share with other professionals if the person goes into hospital what you know are the early signs, early warning signs for the person that you're supporting, and passing that detail on. Now,
absolutely. I think the thing about it is you've got to be mindful that they won't know the person as well as you, so they won't often pick up changes. So again, it's important. Again, if a person goes into a care home, it's important to pass that on too, you know, because again, the care home staff won't know what to look for. So it's helpful to give them a kind of heads up really on the early warning signs as well.
Okay, so we've talked about how important it is to catch it early, and some of the experiences that a person with dementia can have with it, which obviously is going to make them feel very physically poorly, but also can really have an impact on their mental health. But it also has a huge impact, doesn't it, on a carer's well-being as well. And we've had one of the comments that have come into the box, and it is a comment, but I wondered if you wanted to come back on it, because certainly from my experience it's true. This person says, my dad can get quite nasty and accuse his family of hiding things or taking them. It's so difficult and upsetting.
Yeah, unfortunately, one of the symptoms that people can have is they can become quite paranoid. You know, they can have delusional beliefs, and they can start to think people are plotting against them, or they're trying to hurt them in some way, and they really believe that, you know, that it's just the way that their mind works at that point in time, and it feels very real to them. And sometimes, no matter what you say, you know, to try and challenge that, you know, it just doesn't make any difference. It's the person's belief at that point in time, you know. And I think sometimes it's better just to step back. And it's very, very challenging for family members. What you might find, they might trust somebody else in the family, so you can maybe alternate or swap around a little bit. But it's really important family get some time out from that situation, and you know, recharge their batteries, I think, because that is really emotionally draining when you're being accused of, when you're trying your best. So yeah, but it is just a symptom of the delirium, and hopefully if you can, you know, find out what's the underlying cause of the delirium and put treatment in place, that should actually you know, ease off, and eventually go away. You know, hopefully that's the case for most people.
So yeah, it's that prevention, isn't it? It's that early treatment, but also, as you say, looking after yourself wherever possible, taking that sort of time out from the room, even if it's for a couple of seconds for a deep breath, and then also somebody to debrief with, or someone you can share it with, because like you say, people respond to different people in different ways, don't they?
Yeah. I think what you tend to find, quite often people with delirium, if there's a family member around, it tends to settle them a little bit, but you can't do that on your own. So what a lot of families will tend to do is they'll have like a rota, you know, so they'll take it in turns to spend a few hours, and then somebody will come and relieve them. And quite often it's helpful to stay overnight with somebody with delirium, even if they're in hospital. They'll make allowances and help you to do that, because sometimes nighttime is a more difficult time for the person with delirium. But again, a family rota or friends just helping out with that can really help, because, you know, the carer isn't, you know, they can't do everything. They need that time out and that rest to just recharge their batteries so they can continue in the caring role, really. So it's important.
And it's really, really important, but sometimes it's quite tricky, isn't it? And we've had a comment that says the family members haven't been to see the person with dementia as it upsets them so much. And so they're not there to help out because they find it too difficult. So sometimes people do find they're on their own, don't they? And we have got a 3-week course that looks into delirium much more, haven't we? But how you can support yourself as well around that sort of well-being, because the ideal are there are other people who can help you out sometimes, but that's not always the case, is it? So
exactly, that's right. People don't always have big extended families either, you know what I mean? And it's just, a lot of people get older, they lose their contacts, you know, so their circle isn't as big. It can be difficult, but, you know, I think there are options out there to, you know, to get professional support, as we know, and we can help people to kind of go down that route, you know, where they might need to access that type of support. But it really is quite important, you know, if you're on your own, that you try and ask for help. It's sometimes difficult. People feel that they should be doing it, so they don't ask for help and then they end up burning out. But delirium, dementia is difficult to deal with for a family carer a lot of the time, but delirium is even more difficult because it's very acute and it's very intense at the time. So again, for that period where the delirium's in full swing and the person's really unwell, I think it's really important that the family member gets a bit of support, even if it is from professionals.
So I've just got one more question, and then I'm going to come back to this idea of support and just to let people know about how we can support you in the coming month or so with the course that will hopefully help well-being for people who are caring for somebody who does have delirium. So it's just one more question really, Lorraine, and that is, it talks to something you were just saying then. How long does delirium last for, and can it come back?
Yeah, it's very difficult to say. Sometimes it can, within a few days, we can see a change in the person if we find out what the underlying cause is and we can get the treatment in, if it's an infection, we can treat them with antibiotics. Sometimes we see a very, very quick turnaround, but for other people, it can be quite complicated. Sometimes there's more than one cause, there can be underlying things. So you might get a urinary tract infection, then you might get dehydrated. So there can be a few things that can be going wrong at the same time, and we need to get them all sorted. So it can take time. So there's no definite number you could give people, and there are some types of delirium that can last a bit longer. So there's a type now that we talk about called persistent delirium, and that can actually last for up to 6 months, and maybe for some people even a bit longer, and it can come and go as well. So it doesn't always go away completely. It'll go away, but the person might have symptoms again at some point. So it's a difficult thing to answer because it's very individual and different for everyone.
Yeah, so there may be peaks and troughs, but this may not just be, acute. We think of a few days, don't we? But this can be really elongated as well.
It can do, yeah. It just depends on what's going on, underlying problems with the person's health as well, yeah.
Okay, thanks, Lorraine. So I just want to sort of cover really that Lorraine's answered some questions, I think, fantastically well during this session, and thank you for that, Lorraine. But obviously this is a huge topic. We do have more information on our website, and we will put a link to a blog that actually, Lorraine, you yourself wrote, didn't you?
Yeah, that's
regarding
great.
delirium. So we'll put that link into the chat. But as I sort of mentioned earlier, we are running a 3-week course with Lorraine, and it's starting on Friday, the 18th of February. It runs from 2 till 3:30 across a 3-week period. And we will look much more into medications and types of delirium, preventative measures, things that you can do to support the person, because lots of people have put comments about hallucinations and what do I do about that? How do I support someone? So we'd really encourage you to come along to that course. The course runs, as I say, for 3 weeks on Fridays from 2 till 3:30, and you can book onto it from our website, where you can also find all of that other information. The sessions that Lorraine will run in February are slightly different to this session, because we will have a small group. We have up to 20 spaces, and if they fill, we'll put the course on again. And in those sessions, I'm right, Lorraine, that we do, you provide, each week you provide some information in a sort of PowerPoint setting, but then we have 2 practitioners on the call, and it's very much a discussion group, so carers can support each other, share ideas, so it's quite interactive. It's a safe space. We keep it small, and I think that's got great benefit, isn't it, Lorraine?
Yeah, absolutely. I think being able to kind of hear what other people are saying and learn from what they're doing, but also have a safe space to say what you think and say what you're worried about, I think can be really helpful. And I think a lot of people give us very positive feedback about these sessions. Yeah,
absolutely. And it's really good support if you are one of these people who can't gain support from other family members in the moment, to come and just have that downtime where you can say exactly how you feel and you're not judged for how you feel or anything like that. So please do go to our website, have a look. There's lots of feedback we've had on these sessions, at the topics as well, and it's been really beneficial. So thank you so much for everyone for joining this session. Thank you so much for Lorraine for taking all of those questions. And thank you for everyone who's put the comments into the box for us. It's really, really useful. There were a couple about medication, Lorraine. I didn't cover those because I felt that's quite specific and it would be done more detail if we did it during the course, and also if we need to respond to anyone, then we can do. So don't forget to visit our virtual carer centre for more practical information and advice on delirium, but lots and lots of other topics as well. And we will be back with another Facebook Live soon. Have a look out for it in our adverts on Facebook. And again, thank you so much, Lorraine, and thank you everyone.
Thank you.
Thank you.